hospital?
I do. Yeah, I usually do it in between patients and stuff. I go to this area or a room that's not taken. I'll do a brief thing. Obviously, the cases are done in the room, and
Right.
very few I do at home. I have 4 kids, and it's hard to have a quiet time that I can just do it. So,
Yeah. Awesome. So yeah, we pretty much discussed everything on the call. But do you have any questions for me? I just saw that you signed the agreement, so I appreciate that. And yeah, that just means, like I said, exclusivity deal between us and you not working with another production company. But your YouTube page is obviously great. I mean, if you were to get 2 million followers tomorrow, you know, that would be a
Awesome.
great thing.
Mm-hmm.
So yeah, thank you for that. And then I'm just going to go through and I'm going to ask you some questions about, you know, your background, where you work now, ask you about your YouTube, ask you about the types of cases you encounter, ask you to tell some stories. Just, you know, what makes you unique, not only your YouTube page, but, you know, as a doctor.
Yeah.
Awesome. So you start, and then just like you do in your YouTube videos, like when you have like a lot of energy, which is great, which is perfect. So just like bring a lot of energy, a lot of excitement. You know, I know you're passionate about what you do, so that's super important. And we just want to be able to showcase that.
Yeah. Understood.
Great. So yeah, just lots of energy. Try to look into the camera instead of at me when you're answering questions. Try to use the question in the answer. So, you know, if I ask you, you know, what's the craziest case you've ever worked on? You'd be like, one of the craziest cases I ever had. And then you'd go into the answer. Just because we're recording your side, not my side, so we need full context.
Sure.
For everything. Awesome. And then another thing is try not to move the camera too much, because I see you doing that a little bit already.
It's right at my knee, and that's why. Okay, there we go.
Oh, really? Okay, perfect. Great. Do you have any questions for me?
No, I'm excited you guys want to do this. I'm hopeful to the prospect. I just hope it can turn into something else. You know, I don't want to get my hopes too up. This is really exciting, but
yeah, hey, me neither. And it's not, unfortunately, it's not up to us. You know, it's having to get a network to buy in. But like I said, you know, we have these relationships. We're a full functioning production company. So, you know, I really believe we can get it, and we'll make sure that everyone that would take a chance on a show like this will see it.
Mm-hmm.
I mean, like A&E just had like the Tobro, and they hadn't ventured into the medical. So there's tons of networks sort of venturing into the medical these days.
Gotcha.
Probably because of Dr. Pimple Popper. She's great. I love Pimple Popper, to be honest. So.
Yeah, I mean it's awesome. I mean, she being a dermatologist, you know, she's got scheduled cases, she's got office, she's got ways to. It's been always very hard for me because I meet the patients for the first time, and I have to break the question. Hey, you know, I have a YouTube channel. Do you mind being on camera here? And it's much harder than if you prepare them for it and stuff like that. So. And you never know what's coming.
Exactly.
You know, they're literally in pain, they're upset, they're what's going on, and this guy wants to record me. So it's been a learning curve to try to do it in such limited time, earn their trust, and still do it. But I started doing it way far ago. I started in 2011 or something, posting videos and things like that.
Awesome. Yeah, I get it. It's like totally different with the ER versus like a private practice, like dermatologist.
Yeah.
But yeah, I mean, that's something I'll let the network decide if there's enough cases or if they think there's a high enough volume.
Mm-hmm.
But right now we'll just, you know, showcase what you actually do. And I mean, you do get some cool things. So
Absolutely.
I think that merits, you know, consideration. So yeah. So I'm gonna have you start off by introducing yourself. You know, just like you would in one of your videos. Say your name. Say, you know, you're an emergency medical doctor, where you do it, and then tell me a little bit more about yourself. And feel free to ramble on because we'll cut it up to make you sound great no matter what.
Yeah, thank you. All right, well, let me tell you about me. My name is Dr. Carlo. I am an emergency physician, and I love emergency medicine. I graduated from the University of Puerto Rico and went to the United States to do my residency, which is training specific for emergency medicine. and I graduated there in 2013. So I've now practiced for roughly 16 years. I work in the smaller community hospitals. I work in big trauma centers. I've worked in the intermediate hospitals, and I've done it all. Anything from major trauma to teaching hospitals to the smaller hospitals where you sleep a few hours during your shift. As for me, I'm a father of 4 teenagers, 16, 15, and then a 10-year-old boy, and then another little girl at 7 years old. My favorite hobby is actually my profession. I love what I do. I love emergency medicine. I love the fact that I have to know the whole entirety of medicine to be able to treat whatever comes through the door, to be able to quickly assess a patient, treat him, get him the right way to the right specialty, have to deal with both the physical health and mental health of patients, to deal with a little baby with a fever and a mom who's ready to deliver a child from minute to minute. That's just the whole excitement of emergency medicine. Coming out of residency, I wanted to be in teaching, and my first job was in a teaching hospital where we did have residents, not in emergency medicine. I work in other hospitals where I've had medical students or residents of other specialties rotating through, but I've never been a full-fledged emergency medicine teaching professor. But in our hospital, it's maybe happening in the next year and a half or two, so I'm really excited about that. And my goal is to be able to get to that place as I start to slow down in my career, to be in a teaching hospital where I can contribute years of experience of what I've learned, what I've seen, my experience, and pass it on to the next generation of emergency room doctors. And this is why I started doing the videos and YouTube. I want to be able to share what I do and my passion for emergency medicine through these little video clips and vignettes and cases and procedures that I post in my YouTube channel all the time, to kind of bring awareness of certain illnesses, to educate the population so they kind of know what to expect in the emergency department when they go through these procedures. And lastly, to educate the next generation of nurses and paramedics and students who are watching these right now. Actually, a cool story is, as I've been posting these videos, I've gotten emails back from medical schools in Europe who are in lecture hall, and all of a sudden they play one of my videos as an example of a procedure or a lecture, and they send me emails back saying, hey, you were just in my school. Or I have nurses here who are going through nursing school. They're techs and they're going through nursing school. And then all of a sudden they said they were showing a chest tube placement and how to do it, and they showed you. And we're like, I work with that guy. So it's really exciting to see that after years of putting this content out there and sharing my passion through emergency medicine and everything, to see some people recognizing me and seeing back. Actually, a couple of years ago, it was a very slow winter morning, and I wanted to do a video on how to do an external jugular line when you put an IV in the neck of somebody. And I actually was the patient. I had one of the nurses come down, and as they're talking, explaining, go ahead and put the IV catheter right on my neck. And I stood there and I took it and I made a video about it. So years later, somebody's watching it and realizes I work in Cartersville Medical Center, which I am now. This is an hour north of Atlanta, Georgia. And he realized that, wait, that's right next door to us. This is the director of a paramedic teaching program. And he reaches out to me and he says, obviously, you have a passion for teaching. You let him do this on yourself just to make this teaching video. And from there, I became the medical director for the program. So now I teach paramedics about pre-hospital medical care, and I supervise them when they come through the ER through rotation. So they kind of hang out with me, see what I see. I teach them cases and whatnot. And then ever so often, we'll do a lecture in their academic world. This next coming Friday, we're going to have a cadaver lab where we actually do simulations with human live tissue for intubation, central lines, IV lines, and so on. So it's been quite a run to see what started as just posting some educational content and not knowing what it would turn into.
Yeah, awesome. That's so cool. And yeah, like I said, I love when you ramble on. You obviously know what you're talking about. So Did you grow up in Puerto Rico?
Yes, born and raised in Puerto Rico. I went to the University of Puerto Rico for college. I started at the prime age of 16. So at 20, I was in medical school, graduated at 24, and moved to the United States to do residency. There is one emergency room residency. Funny story, I was top 5% of my class. I was the head of the emergency room club as our awareness and trying to bring people into the emergency medicine. And obviously Puerto Rico was my first choice. I wanted to stay there. When match day came, and match day is pretty exciting. It's almost like a roulette when you apply and you don't know where you're gonna go. Obviously you've been to places, you've interviewed, you put your list of where you want to go, and you know you've been selected somewhere, you made it to an emergency residency, but you don't know until the day you get your letter of where are you going. And when it came through, it said Pennsylvania, and I'm just shocked. I'm like, what? I didn't get into this program? So I'm like actually really upset about it. So then on the induction ceremony for the Alpha Omega Alpha, which is the Medical Honor Society, the residency director for the program in Puerto Rico is there, and I said, what happened? You know, I'm your guy, you know, you did. So he didn't match me on purpose, he said. He said, you are too talented, you need to be somewhere else where you're gonna grow, and that's not gonna be here. So it kind of forced my hand to go to the United States, go to a great program, and I ended up at St. Luke's Hospital in Bethlehem, Pennsylvania, which did rotations through University of Pennsylvania trauma. I did Children's Hospital Philadelphia. I did toxicology at Hershey Medical Center. So it truly was a great experience, and definitely that pushed me towards a path in my career where I've been exposed to a lot more and grown a lot more by doing that way.
Awesome. That's so funny because we're right here in Philadelphia.
Yes.
That you were right here so many years ago. That's really funny.
I was all over there in the tri-state area, kind of. Yeah. Actually, through residency, we did residency bonding days, and we would go to New York and Broadway. We would do combined grand rounds with some programs in New York. We did like resident competitions, knowledge competition stuff with other programs in the area. So yeah, I was all over Philadelphia and even Poconos. I did some rotation in the Poconos, and it's great.
Awesome. So tell me about where you work now.
So I'm in Cartersville Medical Center. This is a fairly large emergency department in the north side of Atlanta. It is considered a community-based hospital, and we're just on the verge of becoming a level 2 trauma center. That changes things. Most hospitals are level 3. They can handle it, what shows through the doors, but usually you have to ship out certain things. So major traumas, paramedics, ambulances, helicopters, they know they just can't bring them to certain hospitals. They don't have a designated trauma level. So now that we are in that level 3 to level 2, we're starting to get some more acute cases, more trauma, and just being busy with more acuity. We are located close to Atlanta, so within 40 minutes you can be in a major trauma center like Emory or any of the big centers down in Atlanta. We see about 65,000 patients a year, which is a fairly large size emergency department. Most emergency departments see 30 to 40,000. I mean, the mega emergency departments see maybe 100,000 patients in a year. But to the individual, to the physician who's working there, you're always going to see about the same number of patients. An average ER doctor will see 2.1 patients per hour. 10-hour shift, that means 20 patients. You work 12-hour shifts, 24, 26. Up till recently, it wouldn't be rare for me to see 30-something patients in a shift. But mostly medical patients. You'll see chest pain and belly pain and the cough and congestions. Of course, you'll see the nursing home patient who's septic and is very sick with pneumonia or blood pressure issues. Of course, the chronically ill that are seeking access, like dialysis patients or people who don't have a primary care, so they come just for a medication refill. But you'll see the minor trauma, the broken bones that you have to set back in place, the lacerations, of course, the abscess drainage procedures, and the medical stuff like peds and GYN, which is females with female-related issues, and that kind of stuff. So our emergency department, community-based, moderately busy, and it's expanding. In the last 5 years, we've set up a new expansion of the ER. They're now constructing an extra 12 rooms. So the ER, the hospital, is growing. The emergency department is always the door to the hospital. Most doctors in the community send everything through the emergency department. So we truly are the face of the hospital when a patient comes through. You're getting quick access to diagnostics, to treatment, and to get them to the right place in terms of admission, discharge, or coming up with a plan for treatment.
Great. Just because it started to buffer there at the end, I'm going to do the thing where I hang up and I'll call you right back.
Okay.
Perfect. Awesome. So what got you into it? Like, what makes you passionate about emergency medicine?
Well, that's a great question. So what do I love about being an emergency physician and doing emergency medicine is that from minute to minute, you don't know what you're going to get. Overall, you know that today I'm going to get the cough patient and the flu-like illness and maybe a laceration or a cut or the belly pain, the kidney stone. But from minute to minute, you don't know what permutation, what presentation, what weird stuff that I've never seen before is going to show up through the door. You come into your shift, you don't have, I don't have to deal with secretaries, I don't have to deal with an office, I don't have to deal with on call. I just have to be ready when I walk through that door to be ready to start picking up patients, start seeing patients, and do what we need to do to take care of not just the individual patient, but really the department. A lot of times, some ER doctors get focused on what they are doing and their individual patients, but they forget that you are the captain of this big ship where you have to make sure things are flowing well, that you don't spend 2 hours doing this procedure when there's multiple patients in the waiting room waiting for you. So you have to do a balance of patient care and discharges and admissions and, okay, let me take this quick patient and do him because this one's going to take me more time. And it's more than just the care of the patient, but you're balancing the ins and outs of patient flow and admissions and discharges and so on. The fact that, like I've said before, you could be taking care of a patient with a sore throat that he's had for a week, and then your next patient is short of breath and needs an intubation and a central line, and you need pressors and you need to call multiple specialties, and then you walk to your next one and it's an ankle sprain that happened a week ago, and you're like, right, I was just running high at 100 miles per hour handling this sick patient, and sometimes very frustrating because you're dealing with life and death. You just told somebody that their brother overdosed and died, and then your next patient's there because they've had a mole in their back for a month. And it's really hard not to let your emotions come through and choke them or something. You're there to treat emergencies, but to that patient that's showing up, you just have to balance back out and say, well, to that patient, something happened, they're concerned, let me do my best. And the best example of that, I commented to you when we spoke on the phone, it's a day where the ER was dead. It was the middle of the morning, 3 a.m. There was no one in the ER. And from there, we got a major trauma. As I took care of that major trauma, it took me a good 45 minutes to an hour to handle it. When I came out of that room, I had an ER full of new patients. I had at least 10 or 12 patients that had arrived during that time. So now you're on triage mode. You can't really treat every single patient. You just have to go, okay, who's really sick? Who's not? What orders do I need? Next patient. What's going on with you? Let me put some orders. Next patient. And then by the time I was done with that set of 12, then I could go back to the first and try to see, okay, now what can I do? What can I fix? What do I have to leave for the next doctor? Because I'm just overwhelmed. So that is what I love about emergency medicine. I mean, some people say, do you have a good day at work or a bad day at work? The awesome days are these where you do something like, wow, I haven't done this in a while. I literally just saved this person's life. And in TV, it happens every show. In real life, you can go a month without doing something critical that you feel like, man, if I wouldn't be there then and there, if I wouldn't do this intervention, it would have changed everything. Just the other day, I had one of those cases where you just like, this is why I do emergency medicine. This lady had the sudden onset of arm numbness and weakness, and it was 4:30 in the afternoon when it started. Her arm couldn't move. I mean, she could barely lift it off the table. She couldn't really grab things, and it happened at 4:30. Show up in the ER maybe 5:10, 5:15. So she was right on the window of treatment. They called me as a code stroke to the room, and then you have to react fairly quickly, make an assessment, get the imaging studies, get the blood work, and put your mind all into it to make a very critical decision whether or not this patient can use thrombolytics, which is a very potent medicine. Best way to compare is to using Roto-Rooter on the pipes of your home. If that pipe is bad and you throw Roto-Rooter down, you can break the pipes and make a mess. And if you don't have the right selection of patients, you could turn that patient from a little stroke into a major disaster. So you have to go through the checklists, and you got to go through your exam, and you have to talk to the family and get them to agree to use this medication. And in the best case scenario, you started very soon. Like this patient, I think we ended up starting the medication 44 minutes into arrival, which is excellent in any place. And so we start the medicine, we give the medicine as a bolus IV, and then you just kind of sit and wait. Now, as a doctor, I still have to work on, okay, now I have to send her to a stroke center, I have to make some phone calls, and that's what I was doing while we were waiting on the medication. When I went back to reassess the patient, the nurse said that she's moving her arm again. And I'm like, really? So I go to check on her, and sure enough, she lifted her arm, held it upright, and she grabbed me. And next thing happened, we were hugging, because it was just miraculous to see everything happen right. Quick assessment, getting the scan, making the right decision, getting the medication, and then all of a sudden, this patient had a miraculous recovery from having an arm that would be unusable if she would have waited too long, or we would have messed around and not get the right study, to now she's got minimal damage. She can recover and live her normal life. And I've had a few of those stroke stories where starting these critical interventions resulted in a major change to that person. Sometimes saving a life is great, but saving a patient from major disability is even better, because living with a major disability, it's long term. Life and death, I mean, some people are just very old when they come in, they're very sick, and they don't have a chance when they come that sick. But it's rare to have somebody that you can help that much all of a sudden. The other cool stuff that I see, one of my favorite complaints that I see come through the ER is the little kid who can't move his arm because he fell, and the mom's all distraught because the kid's not moving his arm. And this is a very common thing that happens when the elbow comes out of the joint. It's called a nursemaid's elbow. And after you do a quick assessment, you let the parents know, hey, kid's gonna cry for a minute, and then he's gonna be fine. And you do this little maneuver where you pronate the hand and you push on the elbow in a certain way. You feel a tiny little pop, and the kid cries. You walk out of the room, and 5 minutes later you walk in, and the kid doesn't know anything happened. He's moving his arm around, and you truly feel like I was a hero. And it's something very minor to us because we do it all the time. But to that parent that came with his kid with his arms not moving, thinking it's broken and needs surgery, and then all of a sudden, 5 minutes later, they're like moving around and being normal. It's just, that's super awesome. It's just great.
Yeah. Awesome. Feel free to like have a sip of water or anything, because you keep talking a lot. It's great.
I didn't bring any, so I'm good.
Yeah, you're a doctor, so you're used to just go.
Yep.
I guess. I got my coffee right here. So, tell me about, you starting your YouTube page. So if you could just tell me, like, how many subscribers you do, the types of videos you do, or how many subscribers you have, the types of videos you do, and like you said earlier, the overall sort of purpose.
Yeah. So, probably 8 or 9 years ago, I came up with this idea of doing video education for patients, thinking that a lot of what we do becomes repetitive. I mean, once you see a kidney stone, they're all like the same thing, and you walk to the next patient, they have a gallstone, and you end up having these speeches, these little clips of information that you always say. The patient with non-specific abdominal pain, the patient with kidney stone, the people with gallbladder pain, the people with, they need a recheck of their pregnancy levels because they might or might not be having miscarriage. And I thought, how cool would it be if I just had a standard video that I could bring to the room and play for them? And back then, it was maybe the iPod Shuffle and the iPod Color or something, so those devices didn't exist. They didn't want to have Wi-Fi in the ER. So I was planning on making DVDs and just have a DVD player with 10 videos. If you're getting a blood transfusion, if you're getting a central line, if you're getting this, then make enough videos so I could walk in, play it for the patient at the bedside, save me time, so I can do all the things, and the patient would have the same explanation the other patient got, detailed, because a lot of times we're rushing through things, so we might not be as detailed or as exact as we need to be. So that's how the idea started. And I started making those videos. I wanted to find a platform to load them up. So I thought maybe if I could just send the patient to that video instead of having a machine and having to play it. So I started posting them on YouTube because it was free. And so I would say, hey, I have a YouTube video. You can watch it and it'll tell you more about gallbladder. It will tell you more about kidney stone and so on. So I would teach him or give him a link to find the video. So as I started doing that, I started creating more and more of these videos. And they were strictly educational for the emergency room visit. As I'm doing the videos, I found, well, I need some kind of stock footage of certain things like a procedure being done or an IV being done or an injection being done, so I could include that on the video, make it more fun, more visual. And I started asking patients whether or not I could record certain parts of their care to include it in these videos. And as I started posting those videos of actual patients, actual procedures, then those became viral in a sense. They started getting tons of views, tons of comments, and then my subscription base started going up. And I'm like, okay, so people want to watch the actual patient care, the actual interaction. So I started kind of looking for the opportunities of me to record a procedure that we do in the ER, whether it be a laceration, an abscess drainage, maybe a finger being reduced because it's dislocated. So I started posting more of those. It started growing and I started seeing that kickback of, wow, this is turning into something awesome. I'm getting lots of comments, a lot of interest. And start doing more of those and less of what I initially intended to do. But that's how my channel started growing. And started growing and growing. 8 years ago now, I have 320,000 subscribers today. I have, more than 20 combined million views on my channel. But things change over time. After you do so many of the same, then, okay, I'm not going to post another one of these. Although people don't mind. They want to watch this kind of stuff. So I'll select. I'm more selective now. It has to be something different. It has to be a different complication or permutation of a case to really go through the trouble of making a video. Not only for consent purposes, privacy purposes, but the time it takes to sit down and edit and make it and then put it up on YouTube. It's a lot of work, so I don't do just the regular cut, the regular incision, the regular patient. Now that I have a base of close to 1,800 videos, I kind of select more of what I put in and whatnot. Actually, in the last 6 months, my focus has gone back into the patient education content, trying to improve what I've already done. Some of those videos I'm redoing a little bit better, a little more in almost like if you were at the bedside and I was right there next to you telling you things. That's kind of what I'm trying to do with some pictures, some video included on that video explanation. But I still do those procedures, and as I move forward, I then post things of interest, like if you're a medical student, what tips should you know about the application process to residency, what's ER residency like, and a couple things about myself and what's ER life, the life of an ER doctor, like going through the stress of going home after a bad case or after a bad shift. and I'll do runs of, oh, today was a busy day, let me just go through the patients I saw and what I did. And so every week I find myself posting this or the other. And one, it keeps me studying because I want to keep my knowledge base good so I can answer the questions. You'd be surprised how smart people are asking questions about the videos and about procedures and stuff. Whenever there's a new update on like flu or measles or vaccinations, I'll try to put something together, make a video. It's become a hobby within what I like to do in emergency medicine. Again, bridging what I do or want to do with education of patients and people. So this has given me that window of opportunity to just reach out and get something back from the people watching.
Awesome. Which of your videos has the most views and how many?
Good question. So that depends, because some of the videos lately have been flagged and taken down, and some of them are considered too gory for YouTube. But the top 2 videos are just a simple finger dislocation, and it's just very attractive because the thumbnail picture, the finger's like 45 degrees to the side, and it's just a simple reduction where you just pull the finger in place. It's maybe a 1.5 minute video of a reduction, but that has somewhere around 5 million views. And the other video is actually the story of my own son. We were at Stone Mountain Park having a holiday, and he was jumping on the rocks, and my wife's like, he's gonna get hurt, you better go get him. And when he tries to jump from a big rock to a little rock, I try to catch him and actually made him trip over, and he bit his tongue. And so all of a sudden he's like bleeding out of his mouth, he's running through the park. I grab him, I'm thinking, oh no, he bit his tongue. But most tongue lacerations are not a big deal. They really aren't. They repair themselves, they heal great, they're very low risk for infection, stuff like that. So, but when I had him stick his tongue out, you can literally see a smiley face on the tongue. I mean, this thing was big, it was gaping, and I'm like, oh no, he's gonna need stitches. So I tell my wife, all right, I guess we gotta drive back to my hospital and get him fixed up. And she just stares at me like, you're not gonna fix him yourself. I'm like, sure I am. And she's like, no, you're not. So we ended up stopping at the Children's Hospital in Atlanta, and it was a great experience. They had a doctor for sedation. They call in a plastics resident to come in. And so I didn't get the actual procedure video, but I did some videos pre-procedure, of him showing his cut, and then after the sedation, him recovering, showing the stitches and stuff. So that one's somewhere around 5 million views as well. And the more common theme of what's very popular on my channel are the little pimples and pops, the abscess drainage videos, infection, and things that you do. Actually, some of the videos I consider to be really good don't break the viral threshold, and some of the ones I think, this is just more of the same, get viral views. So I don't understand it, but I guess people are their own judges of what they want to watch.
Yeah. Awesome. So give me sort of, a laundry list of, I know you've already rattled off a few, but of like the different types of things you can see in a day, and feel free, just go as extensive as possible into like all of the different things that you've seen. Mm-hmm.
So when I work in the emergency department, we see everything of medicine. We see kids with a piece of headphone stuck in their ear and you have to remove a foreign body. Then I see somebody with a sore throat and cold symptoms, flu-like illness. Maybe it's the flu, maybe it's not. We see the patient that was just seen last night for back pain and comes back because he needs more pain medicine. We see somebody come in with a medication refill because they can't afford to go to their primary doctor. They've run out of their diabetes medicine. But then we'll see the next patient is somebody with an acute stroke and they can't move their face, they're talking slurred, and then you start handling that, and then your next patient is a belly pain and flank pain and they're vomiting and they're in distress and ends up being a kidney stone. And then you move forward and you're discharging, you're moving through. The next one's a chest pain, and it might be a mild chest pain or atypical chest pain, or it could be a full-blown myocardial infarction that once the EKG identifies the abnormalities, you got to take emergently to the cath lab. Then you might get the nursing home patient who's chronically ill and they're just weak. Literally, that's the complaint. They don't know what's wrong. They just know something's not right. So you have to be a detective and start looking at everything, their past medical history, what they've been here before. Maybe it's something related to that. Maybe it's a new infection. So you have to do a battery of tests to sort things out. And then the next patient might be, again, kid with a fever, and then a repeat belly pain, or this belly pain is acute and they never had it before, and those are interesting. And this next belly pain is they've had it for 3 years and they've been to primary doctors and a GI doctor and they've been to a specialist, and they're here because they want you to figure it out. And those are the really frustrating cases, actually, because it's very low likelihood you're going to be able to help them the way they want to be helped, because it's an emergency department. We are good at emergencies. We're not so good at chronic pain and chronic conditions. But on one day, you can see everything from a kid to trauma to a broken bone that needs to be reset to a laceration, minor trauma, eye complaint, like they got their eye scratched or they have severe eye pain. We see tons of people with hypertension and basically complications of their medical care, which has not been done. They don't have access to a GP. They haven't been a doctor in years. All they know is today they check their pressure and it's 200 over 120. And then all of a sudden you're like, whoa, you got to assess them, get the diagnosis, get the pressure under control, probably even admit them to the hospital for blood pressure control. And so it is, the excitement is not knowing what's next. How is this patient different from the next? And on an average day, like I said, you're going to see anywhere between 22 to 25, 28 patients. On a real busy day when you're smoking through patients and moving through the ER, you might get to 30, 35 patients. I think the most patients I ever saw, I worked what they called a mercenary shift in the middle of Carbondale, Pennsylvania, and it was a snowy day. So everything else shut down. I couldn't leave the ER. The new doctor couldn't come in, so I had to stay in the ER longer and ended up seeing somewhere around 40-something patients in one 12-hour shift. And there was no one else. I was the only doctor in the ER, so anything that came through the door, my responsibility. So I treated a heart attack that I gave thrombolytics to and then had to helicopter him out of the ER. I saw Tylenol poisoning from somebody who took too much Tylenol. I saw, of course, the belly pains, the minor lacerations and injuries, the chest pain workups and everything. But even though it was a very tough day, that's the day I remember, the day I saw 45 patients. It becomes a little chip on your shoulder, like I did it. I was able to handle this many patients and see that many. Actually, I'm probably one of the ones who always counting how many patients did I see. I want to quantify how much I've done, and the best days for me are the days where I see 30 people, and the days where I feel like, wow, the ER was a mess when I came in. I saw everybody, I took care of them, and now the ER's clean, and I did my job. Like I was saying before, it's kind of that captain of the ship feeling of I'm coming into the ER to not just take care of the individual patient, but take care of the whole department and just clean it up. So that's what a typical day is like in the ER. So of course it depends on whether you're working the morning shift, you're working the night shift. That kind of changes a little bit. So the night shift, your job is to clean up the ER for the morning guy. The morning guy is keep it running, and not mess it up for the next guy. I usually end up working what is called the middle shift, and I am the floater. So when I come in, the ER is already busy. It's in the busiest hours from noon to 11 o'clock. And my job is to go wherever I'm needed. Where in the ER is there a bottleneck? Where have patients been waiting too long? And if I have to get to the waiting room, if I have to see people outside, if I have to grab urine and send it to lab myself, I will do so just to keep the ER moving and keep things moving for the patient.
Awesome. So can you give me a type, just sort of a list of like, what are, I know you can do like surgeries and, obviously run tests. Can you give me like a scope of like what you can handle? Because as you were saying, like in the ER, like you have to be able to do everything. Mm-hmm. So if you just like start off by saying that and then just give me sort of another just like of things that you can do specifically.
Yeah. So an emergency physician has to be ready to handle anything that comes through the door, whether it be something that you do just stabilizing treatment or something you do definitive care. But we can do anything from minor procedures like sutures, lacerations, splinting bones that are broken, but also reducing or realigning broken bones, reducing major joints like a shoulder dislocation, a hip dislocation. Sometimes a person comes with a rapid heartbeat and you need to sedate them and actually shock them with electricity to convert them to normal rhythm. You need to be able to be a surgeon in the sense that you need to be able to do central line placement, which is very big vascular access procedures. You need to be able to do multiple difficulty levels of repairs, almost like plastic level repair, simple repairs. You need to be able to do, like I said, bone reductions and a lot of orthopedic stuff. And in terms of major procedures, it's rare, but you need to be ready when the time comes to be able to open a chest open and do manual compressions of a heart. It's very rare. I've done it twice in my career. You need to be able to deliver a baby if it needed be. It has only happened maybe once or twice that I've actually had to deliver a baby emergently, because most of the time you can get them quickly to upstairs where there's trained people, trained nurses and stuff. But depending on the hospital you're on, some places there's nobody else in the hospital, 3 in the morning, and this patient comes crowning and delivering a baby, and you have to do it. Same thing, a patient's crashing and they need a chest tube, or they need a central line, and they need intervention in the airway, or they have a very difficult airway because their tongue's swollen, it's all bloody, and you have to cut the neck and put a tube down their throats and do a tracheotomy. You need to be ready to do all of that. So an emergency doctor, depending on their work, on where they work and how acute they work, they get these procedures often enough to keep their skills. Some places they don't, so they need to go to special labs and practice ever so often to keep their skills up. Where I'm at today, you get these procedures often enough that you don't lose your skills, but they don't happen every day. And that's a good kind of balance. Some places they do central lines and intubations and major resuscitations on a day-to-day basis, which is why a lot of ER doctors end up getting burned out, and they're just like done, because there's a lot of stress in people in the verge of death and life and death, and we don't always win. And that's the sad part of our care, and having to deliver the bad news and having to be empathic and have that quality of be high and doing all this stuff, and then sit down for a minute, calm down, and give this terrible news to the family of a life and death situation, or a life-ending diagnosis, like tell them I found cancer and it's already everywhere and this is bad for you. So not just the mechanical part of emergency care where you do all these different procedures, but also the human side of really caring and being able to sit down, to communicate properly, to make good eye contact, to be a human again. And that gets really hard the more you do emergency medicine, because you get frustrated and burned out, and a lot of doctors end up losing that empathy, that human character, because they've seen it, they've done it multiple times, and they forget how it looks when you're on that other side. I can tell you, I don't know if I had any interest to this, but about 4 years ago, I was on the receiving end of medical care when my wife had a really devastating brain infection. It's called encephalitis. And for when she got sick to the next 2 weeks after that, where she was acutely ill, I was in a neuro ICU with her and didn't know if she was going to live or die, or if she lives, what are the long-term side effects. She stopped recognizing me. She didn't know our kids. She was just not herself. And I was able to experience the other side of the anxiety of knowing what's going on, for the doctor to tell me what tests are going to be done today, what's the next step, what's going to happen. And once she recovered and we came back from that and she got better, of course, with some disability and some issues, my practice changed dramatically. And my empathy, my ability to stop and say, I need to explain this more. I need to take my time with this patient. I need to let him know I understand their frustration, has changed dramatically after going through that experience. So emergency medicine, as it evolves, you evolve with it. You become a better physician, not just as a practitioner, because you diagnose better, but you treat better, you're a better human. And that's something I'm constantly working on. And surprisingly enough, these videos and the YouTube has shown some of that, because on some procedures, I'll be very talkative and I'll explain things, I'll be very detailed, and some of them I'm very quiet. And then I get a lot of feedback and comments like, why weren't you, talking? Why weren't you explaining? This patient said he was scared and you didn't say anything. And to see that, and I'm like, wow, yeah, you're right. I wasn't being as attentive. I didn't recognize that he was anxious. So over time, you can see those comments getting better and better. To one of the last videos I posted, people had this overwhelming response of being like, you were just so kind, you were so nice, and you took your time, and so I was like, wow. I mean, I've learned from this experience. I've learned from what people are seeing that I'm not. I thought I was doing a good enough job. And then all of a sudden people are calling me out on, no, you weren't nice. You were just going through it, or the patient was in pain and you didn't numb him enough. Or so it's been a great experience to do all that.
Awesome. So yeah, you were getting into it a bit, or you've definitely spoken to it, but what would you say sort of makes you unique as a doctor? And what do you feel like makes you stand out?
I think I'm very okay. Let me rephrase that back to repeat that question.
And don't worry about being humble.
Yeah. So what makes me unique in the ER, or what I pride myself in when I'm in the emergency department, is I keep constant attention to the flow of the emergency department, not just my own patients, but where can I help? And I'll do anything from changing a bed, cleaning a room, moving a patient from point A to point B, anything that's going to help the department. Now, a lot of doctors don't do that. They sure say, hey, I need the patient moved to this room or that room. I need a urine on 5. I need this or that. I'm the one who goes and gets it done. And I think maybe from my background, when I was a medical student in Puerto Rico, medical students did everything. All the nurses' job, the tech jobs, the drawing blood, the taking the blood from here to there. And it's always kept me humble in a way that I'm not above anybody to do anybody's job. Ultimately is the care of the patient. And if I have to do the wrapping or the splinting because the nurses are busy, I will do that. If I have to go and sign off the patient, sign here so they can leave, I will do that. I'm very organized when I'm seeing my patients. I keep a list of stickers, and I always go back to them to, okay, I'm here, I'm there, this one needs this one needs that, and always come back to them so I don't lose track of them, so I can keep the ER moving. The mid-level providers, which are nurse practitioners and physician assistants I work with, if they were to say what makes me unique to the others, I'm very reachable. They feel like they can come to me and ask me questions about their own patients, about their care. I always kind of slow down and take my time to go through it and explain. Sometimes they feel like they can't reach out to other doctors. They don't want to bother them. They don't want to interrupt them. So I'm always available. I'm never above stuff. And maybe that shows in how I call myself. When I'm in the emergency department, I'm not called Dr. Oyer. I am Dr. Carlo. I've always been Dr. Carlo. I go on a first name basis. And it's because I want to be, easily remember. Carlo's a lot easier than Oyer, but also reachable. And the nurses can come to me and ask me questions. And sometimes I'll notice that maybe I was a little short and that I cut that nurse short, or I was a little rude. And then I'll go back to them and say, I'm sorry, you were doing your job. You were right in approaching me. Please don't take this the wrong way. I'll do better next time. So I'm trying always to keep myself grounded and never have this doctor chip on my shoulder, even though I am. I want to be respected, and I want the patient to feel that they had a good doctor, that, he wasn't like trash or not educated enough, but also reachable. And one thing that I've started doing recently that I don't know any doctor that does it. Some of the times we call patients back and follow up on them. I make a point to at least 6, 7, 8 patients a shift to write their numbers down, and during my next shift, take a moment to text them to see how they're doing, to follow up on their care. And it's overwhelmingly positive, the response I get. It's just like, I can't believe that you took your time to follow up on my care. And because it's going to sound like cliche, but I do care about what happened after that visit. I do care that they perceive me as a doctor who care for them, even though, God forbid, I missed something. I was hazed and I was rushed when I saw them. I want them to feel like they had a good experience and that I care for them as a person, not just as a patient. So that's what makes me me. If my son ever actually makes it to medical school, he wants to work with me when he grows up. That's probably what I would push more. Not the clinical competence, but the humane competence. Just being available, taking the time to listen, doing the best you can for that patient, given what you can do for them that day.
Awesome. Hold up. So it started buffering right around the Dr. Carla story, or that you go by Dr. Carlo. So I'm going to hang up, call you back, and we'll just get that part
Okay.
again. Great. Perfect. Yeah, what I really liked what you were saying, I don't go by Dr. Ogier. I go by Dr. Carlo. So could you just sort of say that again?
Sure. So one of the things that I think really shows how I portray myself in the emergency department is that I go by Dr. Carlo. My last name is Dr. Ogier. My father was a pediatrician. He was Dr. Ogier. And I know in the English, nobody can say it right, so the people try to say Dr. Oller or something like that. And I usually just introduce myself as Dr. Carlo. One, is easy for the patient to understand and to say it back. And number two, it gives me a personal basis of just being Carlo. And Dr. Carlo makes it easy, makes it approachable. And I think that makes me a little more unique. I want them to feel that way, and some of them will not, and they're like, no, it's your last name. I said, no, it's okay. I'm just Dr. Carlo. I mean, and I've seen some articles published about dropping the whole doctor thing. That I don't believe so much in. I think patients want to that clear title that you are a professional, that you are taking care of them, but that you're also human, you're also reachable. So to the nurses, to everybody else in the department, I'm Dr. Carlo, and sometimes I'll kid around and said, you can call me Dr. Carlo, kid, hey you, whatever, just reach out to me. So that's that story, and we have this patient boards where we update our name and we write it down so patients know who's taking care of them, and I write Dr. Carlo right on it, and that's different. I think that makes me unique in what I do with each patient. Something I do with my patients that I routinely do and try my best to do is to always explain what I'm doing, why I'm doing it, and about how much time things are going to take. These are all techniques to improve patient perceptions. But being on that other side, when my wife was sick with the encephalitis, I truly believe I needed that. When I was on the other side and I wanted to know who are you and what's your role and what's going to happen today and how much are things going to take in terms of time. So from those experiences, I've learned to do things my own way and to incorporate those into my care of patients. And that's developed into this follow-up text message and phone calls that I routinely do on a few patients a shift, sometimes 10 patients, sometimes all of them if the time permits. But that makes it unique, and then I get fed back from the patients when they just can't believe a doctor took the time to follow up on their care. Funny story, one day I was doing this and I was going back and forth with the mom talking about the kid having some vomiting, and I said, well, if you need more medication, I will call it in for you. And that was the straw that broke the camel, if you will. She all of a sudden, she stopped texting back and she called the emergency department. And then they transferred me this phone call, say, hey, this mom that you saw yesterday. So I pick up the phone and said, yeah, it's me. And she's like, yeah, Dr. Carlo, you took care of my daughter and she was vomiting. I said, yeah, I've been texting back and forth with you, haven't I? She's like, well, that's the thing. I didn't believe it was you. She thought it was like somebody who had accessed her account or stole her identity or something, because she couldn't believe that she was actually communicating with the physician. So that's a story I've been saying here and there, because it is truly gratifying to get that kind of feedback, and it's almost like I have to ask for it because you're reaching out first. But it in the emergency department, when you don't get that follow-up, you don't get that patient coming back to you days later to thank you. So a little text message, they go like, yeah, I'm actually doing great. I feel better. Thank you for your time. And it's just, that's the gratification I get from that extra bit of work.
Awesome. That's so cool. So could you take me through some of the cases that you have on your YouTube, just so, because what we want to do is be able to have you talking about a case and then show sort of the video over it. So if you have like the video of it, like you were telling me that, I mean, I saw you have the chainsaw one. If you want to take me through that first, and you can cut it, you can condense it a little bit.
Okay.
But if you want to just take me through some of those cases that you have up there, or examples that are similar to things that you have footage of.
Okay.
Is that possible? All right.
Well, let's go ahead and go through some of the cases, some of the more popular videos, and I'm not going to be selective and select the cases. I think they're pretty good because it shows what I was expecting and then what came out of it and the difficulties with it. There's one that's called the largest splinter in the leg, and it's a patient who was working and kind of run their leg through a piece of wood and thinks they have just a splinter in the leg. So there's just this tiny little piece of wood coming out of the skin. It's just a very tiny thing, and we just get it ready for the procedure, and we numb it up, and we talk about what we're trying to do. And as I try to dissect through the tissue and get this piece of splinter out, I found out that it's much deeper, much bigger than I thought. And I try to grab, I have to numb further, I have to do a little bit of lessening the tissue around it so that it can actually come out. And finally, when the splinter does come out, it's this big, and it's just like surprisingly big, and it's like this is a stab wound. It's not a splinter, you know. So that was one where you think you're heading towards a very minor procedure, ends up being so much bigger than you think. So that was a very good case because it highlights the fact that you have to be ready to turn a little procedure into a major procedure, and then you have to be careful to inspect the wound well to make sure you get all of the foreign body, and then treat the patient, of course, compassionately and make sure their pain is free. There's another case recently which got a lot of positive feedback from patients just because it's a good story. It highlights the problem with a lot of patients, and ultimately the care did improve her outcome. It's a lady who has very poor follow-up care. She was hospitalized recently, had partial amputation of her digits because of vascular disease and diabetes, and she had an infection in that surgical site. So I had seen her a couple weeks ago and admitted her for a foot infection related to that wound. Then she shows up like 2 weeks later with an even worse infection and a big abscess showing up in the other foot. And it ends up that she couldn't afford to go to the outpatient setting to get the antibiotics that were prescribed to her. So because she didn't take care of herself, she ended up having worse complications and needed further care. And on the procedure, they'll show an abscess drainage. So we'll do the clean of the wound. We'll do the incision of the wound. We'll get the infection out of it. We'll then wash it and clean it and drape it. And then we have the other foot. I mean, like you do one and then the other foot also has a bad infection. So we do a procedure there. And what was impressive is the amount of infection that was in that foot. The fact that people try to access care but they can't for different reasons, and how those complications lead to worsening disease, chronic diabetes and medical diseases that don't get treated. The social aspects of care where access is an issue and they don't have the money to afford this or that. So that was a pretty cool procedure to watch and to hear the story. One of the videos that had the most positive response was a very simple abscess drainage from a fingertip. Those are called felons. It's an infection of the pulp of the finger, and his pulp was like twice as big as the other one. He was like a tambourine. It was taut and inflamed and swollen, and this patient was just a gem. He was just so nice to the procedure. We incise it, and the pus actually shuts out through the room and hits the wall. And but then we get it all cleaned out and managed. And then when the patient was done and I was done, the patient asked if he could share a poem with the audience, the camera. And I'm like, well, sure you can. It's your video. You allow me to record this. Do what you can. So he gives out a little poem, and people were just so touched by that human aspect of the patient wanting to share that poem. So that was a pretty nice video because it wasn't just a procedure, but also the human nature, and he wanted to share some of that. there's another video which I thought was gonna be like, oh, people are gonna love this video. This guy is such a character. This gentleman was upset, had a fight with the significant other, and took her purse and kind of jammed it against the table, not knowing there was a pencil on the purse, and ended up crucifying him through and going through his hand. So he comes in, he has a pencil on both sides of the hand like this, and he's like, I got, so this is a very minor procedure. Of course, we're gonna check for, the fact that he can move all fingers, the fact he can feel sensation, no major vascular injuries, nerve injuries. We do all that. Once we make the decision the pencil needs to come out, then we numb him, we clean it out. But the real funny story is once he was numb, he looks at the camera and says, you want me to pull it out? And he just kind of like does it right at the camera and takes the pencil and just jams it out. And I thought, well, that was character, like we do all this stuff, we know him, and now he wants to pull it out himself. And I thought that was awesome. It was really fun. He was a big character. And that video, surprisingly enough, didn't have as many views as other minor procedures that I thought were just normal stuff.
Yeah. Tell me about the chainsaw story.
I don't there was a case of a patient who came in with a chainsaw injury, and I don't remember the specifics of how exactly it happened, but it's usually the same story. They're doing some work at home, they're working with some instrument, and they slip, they fall, they miss the branch, and then they cut through their arm. And this is a young patient, probably mid-20s, who presented with a fairly deep laceration of the forearm, through the big muscles, deep layers, and into the possibly the joint space. And of course, a patient like that, again, you're going to assess for vascular function, for nerve function, make sure they don't have any kind of deficits. And this gentleman did have some numbness and tingling going into his fingers associated with that, because it went deep enough to get some nerves, to get some deep tissue injuries. But once we do that examination, then we get ready for repair. Then we numb the patient. We use lidocaine and injections to get the tissue to be numb. And this particular laceration, because of the depth, then we have to do what is called layered closure, where you do the muscle layers, the fascia layers, the epidermis, and then you close the skin. So it took quite a while. I had to break up the procedure in a couple videos because it was so long at the time. I couldn't upload videos that long. So, and then we go all the way to the closure. That particular patient I've actually seen 2 or 3 times for other things later on, and he'll show me his arm and say, you remember me, you did that video and you showed it to, and I'm like, yeah, how you doing? So he was supposed to follow up with a plastic doctor to get a repair of one of the deeper tendons that was not repaired during the ER visit, but he was not able to afford that care, so he never got it fixed. And so he has a little bit of deficit and some numbness in his fingers that never got better. So I guess.
Well, is there one more case or so that you wanted to speak to that you have footage of?
Let me see. Well, we talk about in the phone about some of them. Kind of related to the pencil, I have a case of an arrow through a hand, and this is a young teenager who was doing some bow and arrow, and he had edited the arrow, made it a little shorter, so when he was pulling back on the arrow and let go, it fell off and basically shot himself through the hand. And the video is quite good because we got close, and you can see us having to cut the arrow, clean the hand, and then pull it out. But it also was a very minor thing. He ended up just having soft tissue injury, no bones were broken, no disability resulted from it. So we're able to irrigate the wound, clean it out, and I think I might have done a stitch or two, but this kind of wound you don't want to stitch too closely because they're high risk for infection. So you kind of leave them open, let it heal. And that was a cool case because it's cool to see somebody walking in with an arrow through the hand. That was the kind of case I saw. I'm like, I'm there. I'm taking care of that kid, you know. So it was exciting. It was fun, and it had a great outcome, even though it was quite devastating initially to see that. Then there's the funny stories, you know.
Hold up. You know what? I'm losing you for a second.
Okay.
I only have a few more questions, so let me hang up and call you back one more time.
Okay.